Okay, so hello everyone. I'm very, very honored to be here. And for me, it's quite exciting to be standing here and taking a bit of a perspective with you on the work that we do in the Ministry of Health, and I think we do in the services. I will be talking about the mental health services and changes that it has been going through in the past 3 years. But when I think of this system, the mental health services, I'm always thinking about the movie of The Wizard of Oz. And in the movie, if you remember, it's quite an iconic movie. Dorothy's kind of trying to find the right way. She's trying to find the yellow brick road in order to get home. And she has 3 friends that are actually going in the same path with her. One of them needs the wisdom, and the other one needs the courage, and the third one needs the heart, which is the sensitivity. And for me, this is a very good metaphor for the mental health services development in asking what is the right way and what is home. And I think there are many, many questions that are left unanswered, and maybe only our experience is starting to imply what the answers are. I will tell you about 3 major issues that has been happening in the system and the services in the past 3 years. And I will begin by talking about the mental health public policy. And talking about mental health public policy is very tricky. First of all, mental health is very stigmatic, as you probably know. It's a world of many, many voices. We call them stakeholders, and thus of many perceptions and many sensitivities. And among these are, of course, the patients, and some of the people call them now our clients, which is quite a different word for them. The patients' families, civil advocates, NGOs, NGOs that are fighting for the rights of the mentally ill, but also general human rights movements, legal agents, and of course professional agents. All are participants and contributors to the formation of public policy regarding mental health services. But now changing systems causes ripples, you know that, so courage is required by everyone. An enormous change was made by the mental health reform in Israel, and this was in the provision of mental health services, mainly in the ambulatory care that was very much underdeveloped in Israel. This actually was mending a distortion since the State of Israel was established of splitting body from mind, because before the mental health reform, you could have very good services in terms of your physical health. But if you needed something that has to do with mental health, you would get it from the state, while receiving your physical health services was done by HMOs or sick funds, depends from which country you come from. And this created a very large split between the two. So the reform was actually about transferring the responsibility of providing care to the 4 sick funds that provide the physical care, with an interim organizational period that actually took place from 2012 to 2015. The aims of this reform was to create an integration and thus improving mental as well as physical health of our patients, body and mind integration, to provide services to a larger portion of the public, and to reintroduce to the public the importance of mental health and to reduce stigmatization. But there were concerns, and most stakeholders supported the reform, but still opposing voices and supporting voices pronounced concerns regarding the HMO's ability and commitment to develop high-quality services, the ability of caring for severe mental illness patients, as well as general mental health, and of course allocation of budgets given to the HMOs. This is a very silent public. So theoretically, the HMOs could take large portions of this budget and allocate it to other fields of medicine. And some people worried about the narrowing of the eligibility for treatment, that some people might not receive the proper treatment and would be excused by the reform. So in front of you, you can see what's actually has been happening, and I will just tell you that in 2011, prior to the interim period, only 80,000 people received public mental health treatment by the government, while in 2014, the middle of the interim period, we already had 250,000 people in Israel receiving mental health services, public mental health services, free of charge. And today we are standing at about 340,000. Here you see the numbers of 2016. Now, mental health reforms are long-term processes that you constantly need to navigate, of course, with sensitivity and wisdom with all of our stakeholders. And the second phase of the reform is now shaping, and the future perspectives that we have to consider is how do we establish services for unique populations in the HMOs, like eating disorders. We've already started further developing them, because they do exist in Israel, but not to the extent that they should. Complex PTSD, forensic psychiatry, and other subspecialties which are somehow not as attractive as other fields, perhaps because of their complexity. Further expanding of services and shortening of waiting times in Israel, establishing a reaching out services for crisis intervention for mental health. This is very important, especially for severe mental illnesses, and focusing efforts on the continuity of care between the community services, the hospitalization in Israel, and the reintegration, which is the very good rehabilitation services that we have for the mentally ill in the country. The other things that I would love to talk about, the other topic, that very big issue that happened here about 2.5 years ago, is using restrictive measurements in the field of psychiatry in acute wards. In 2016, the case of Noah, which is of course a false name, was exposed by the media, focusing public attention towards the practices and structure of the Israeli mental health services. And I would just like to tell you that my life before this case and my life after this case has completely changed, because from a topic that nobody actually wanted to focus upon, and it's about the whole public and the media, we have turned to be one of the most centralized public discussions since then and until now. The ministry, back then when the case was presented by the media, had already begun to examine methodologies to reduce restrictive measurements in the acute wards at the end of 2015. But Noah was mechanically restrained for more than 24 days in a psychiatric acute ward, and it was the case of Noah, the media exposure, and a special report done by an NGO that is called Bizchut, I will translate my right, for the human rights of the mentally ill, that really boosted the change and moved the system from a point of stagnation to the point of self-reflection. It was obvious that there was an extreme overuse of mechanical restrictions in the acute wards in Israel. It was also obvious that for many years patients experienced lack of trust in the services, and large part of that can be attributed to restrictions that impinged on their autonomy and dignity. So a dialogue was actually created after this massive exposure. A very good dialogue, was actually created among all stakeholders because of this very misfortunate case of Noah. And all of us, I think that it would be very accurate to say that all the stakeholders and all of us together contributed to a dramatic reduction of 60% in a year and a half in the restraints inside the acute wards. These are all the mental health hospitals that we have in the country and divisions of psychiatry in general hospitals, and we are now standing on 60% reduction. I think we will be achieving a 70% reduction by the end of 2019. So the question is this change sustainable? I think the sustainability is a very main issue, or an artificial consequence of the media exposure. What is the cost of this exposure? So more resources were introduced into the system. Some claim, most claim, not enough. We have introduced adequate alternatives to the ward staff to enable appropriate coping with patients' aggression in the wards, but have we done this enough? Medical professions now do not want to work in mental health services. We have a very few psychiatrists starting their residency, and nurses, they just don't want to come and take care of the patients. Staff claimed that the media exposure was very narrow and mispresented the complexities and dilemmas of their work, and they felt that they were very much devoted to the patients only to be humiliated by the media. So for me, it was like a sort of a very big question, because when you talk about public policy, you first have to ask what is public and who is the public. And maybe there are several ways to consider what is a public, and maybe there are several sub-publics that you have to consider, which is the same question I've been having about stakeholders. Who's a proper stakeholder? Who should you work with? Who should you not work with? And these are very big questions in the realm of mental health that maybe we have to examine. The third thing that we had to ask ourselves is, do we want to stay in the concept of hospitalization in mental health? I think all of us are quite used to the term of hospitalization for many, many years, centuries, even from the beginning, and the existence of asylums all over the world. So I'm calling this combating structural stigma, which is challenging the hospitalization of the mentally ill. Well, hospitalization is required in extreme cases, and especially when risk to oneself or others is suspected. But it also may be traumatic for the patients. It may create hostility towards services and professionals, and even the best quality hospitalization still detaches the patient from its family and its community. So we had to ask the question whether several subpopulations do not require maybe hospitalization. Maybe chronic patients that stay in prolonged wards. Can we integrate these severely debilitated patients in the community? Can we give them some quality of life and dignity? Because to be very honest, the main and the pure medical contribution to these patients is very scarce. In many of these patients, I don't think we have enough medical tools to be creating a change and to be improving their quality of life. So in the past, we didn't have the knowledge and understanding of how to integrate them into the community, and we have now accumulated this experience from 18 years of rehabilitation of the mentally ill to create a sort of a therapeutical rehabilitative constructs, new models. The first one that I would like to present to you is the ecological community, and we're now developing the integrative community. And you can see here that very, very debilitated chronic patients are being moved out of the hospital. This is the first one that we established. It started to work a bit, maybe more than a year ago. It's a very nice place. It's very, how would I say? It's very much, it's very nicely designed, but it's designed from the point of view of the needs of the chronic patient. And maybe we also need to be preventing hospitalization in acute care cases and provide them with a certain alternative before, or maybe to prevent the need to be acutely hospitalized. And balancing houses are one of the initiatives that are now happening in Israel. These were independent initiatives established by psychiatrists and others that believe that exacerbation in patients can and should be contained and treated in the community. The ministry very fast decided to support these enterprises, creating clinical guidelines and monitoring their development, which was absolutely quite risky because we didn't really know what would happen. But we thought we needed to give it a chance for the patients. So this is still defined as a pilot, as we need to balance between the patient's dignity and autonomy, and that the model enables, and between safety elements of the public, of staff, and other patients that need those houses. You can see here 3 of the houses. These are beautiful places. One of them is in Jerusalem called Sutria. The other one is in the north called the House of Hope. And the third one is also in the north called Harduf. Very special places. And the staff is combined from specialists, from professionals, but also from professionals by experience. I'm not sure if you know this word, but these are patients that has actually had severe mental illnesses, and they're now very much quite balanced, and they are also they are taking care of the patient, providing a sort of a different point of view and compassion and containment to the patients. So we also have to talk about innovation, because if we won't say this word, we will not be trendy. So we're also developing all sorts of therapies and mechanisms to reduce aggression inside the wards. And of course, we cannot forget the mental health centers themselves, and this is what's currently happening in the system. We are also changing the look of the hospitalization and acute wards system. This could never happen without one very important thing, the collaboration and commitment of all the stakeholders and of the public. So I thank you all, and maybe we can think about the ethics of and the dilemmas that are stemming from the public policy of creating and planning services. Thank you.